Greetings, everyone. This is Chip Lewis, Director of Communications at NMAC, and it's my pleasure to welcome you to this month's Community Spotlight webinar on HIV in the American Indian and Alaska Native communities. We are very, very happy to have you all join us today. We know it's a busy time of year, so thank you for taking the time to join us. We will get started right away. First of all, little housekeeping. Again, if you're having audio issues, please let us know in the chat box, and we'll try to address those. For the moment, everyone's audio has been muted by the presenter. If you would like to ask questions when the time comes, simply go to the chat box, enter in your question there below, and send it to the entire audience so we can see it. And then we will do our best to answer it in the Q&A section when we get there. A little bit about NMAC. NMAC leads with race to urgently fight for health equity and racial justice and the HIV epidemic in America. Since 1987, we have advanced our mission through a variety of programs and services, including public policy education, national and regional training conferences, including the United States Conference on AIDS and the Biomedical HIV Prevention Summit, treatment and research program, and numerous electronic and print materials. You can certainly find out more about NMAC at our website, nmac.org. This Community Spotlight series, we began this year. It's a series of webinars to celebrate and spotlight communities that bear greater burdens in the HIV epidemic, but are often invisible or overlooked due to issues of race, gender, or gender identity. We have some other upcoming webinars, and you can find out more about our other upcoming webinars to the end of the year at nmac.org/webinars. And today's presenters, we are happy to have with us Rick Haverkate, National HIV and HCV Program Coordinator for the Indian Health Service, and Stephanie Craig, Director of Project Red Talon and Thrive from the Northwest Portland Area Indian Health Board. Thank you to both of you for taking the time to join us today. We greatly appreciate it. And let's start with Rick. And Rick, give me a second to unmute your line here. And you're unmuted. Can you hear us?
Yes, I can, Chip.
All right, yeah, the floor is yours.
All right, well, thank you very much, Chip. I'm really happy to be here, and thanks for the opportunity to talk about HIV in Indian country. I appreciate the relationship that we've been building over the years with NMAC, and I really am happy that folks are interested in taking some time to learn about what's going on with American Indians and Alaska Natives. I'm an enrolled member of the Sault Ste. Marie tribe of Chippewa Indians, and that's located up in the very most northern part of the state of Michigan. I've been working with American Indians as well as Alaska Natives, Native Hawaiians, Asians, and Pacific Islanders since 1989. Next slide, please. I want to give you a short, high-level overview of HIV in Indian country. And for those of you who aren't familiar with that term, Indian country simply means any place in the US where there are communities of American Indian and Alaska Native people. And that includes all 50 states. Most of us live in urban and suburban areas, and we are not limited to Indian reservations. American Indians and Alaska Natives face significant health disparities in rates of sexually transmitted infections, including HIV. And from 2005 to 2014, the CDC reported a 63% increase in HIV rates among gay and bisexual American Indian and Alaska Native men alone, while the overall HIV rate for American Indians increased by 19% during the same period. So you'll see that we do have a disparity within our own population. Our men who have sex with men increased their rates by 63%, while the general American Indian population's rates increased by 19%. Both are alarming, but I wanted to point out that disparity. And in that same report, the CDC also stated that the undiagnosed rate for American Indians and Alaska Natives living with HIV hovers around 18%, while the national undiagnosed rate is at 13%. Next slide, please, Chip. Similar to other demographics, the largest burden of HIV is among American Indian and Alaska Native men who have sex with men. And they accounted for 78% of all HIV cases in our population. That was in 2013, and that was reported by the Indian Health Service's own medical records. However, American Indian and Alaska Native women show a rate of HIV diagnosis that is 3 times the rate of white women. In addition, data looking at racial and ethnic differences in HIV/AIDS survival between 1998 to 2005 displayed that American Indian and Alaska Natives had the lowest survival rate after an AIDS diagnosis of any race. And according to 2013 data from the CDC, roughly 53% of all American Indian Alaska Natives diagnosed with HIV were in fact receiving continuous HIV care. That's 53% compared to 58.2% for whites. And about 52% of American Indian Alaska Natives were virally suppressed compared to 62% of whites who are virally suppressed. Again, a bit of a disparity there. American Indians and Alaska Natives rank 3rd in HIV rates based on race. And a closer look at modes of HIV transmission reveals some startling disparities that can impact the trajectory of current and future HIV prevention efforts. You can stay back on that previous slide if you want to, Chip. There you go, that's good. According to CDC, the overwhelming majority, 73% of HIV transmission among American Indian and Alaska Native women occurs via heterosexual contact, which is consistent with HIV diagnosis among women in the general population. Where HIV transmission for American Indian women diverge from women overall, however, is with injection drug use, whereas 13% of HIV transmission among women overall can be attributed to injection drug use. This mode of transmission is responsible for 33% of HIV diagnosis among American Indian and Alaska Native women, a large difference there. For American Indian and Alaska Native women, this issue is further compounded by the high rates of intimate partner violence that we see in Indian country. More than half of all AIAN women report intimate partner abuse or sexual assault in their lifetime. And these further complicate condom negotiation and other safe and consensual sex practices, and are shown to increase other HIV risk behaviors such as sex with multiple partners and substance use. Next slide, please. In addition, survival rates between 2010 and 2014 were the lowest among American Indian and Alaska Native people. As tribes and their advocates look for promising practices to curb these rates, more attention needs to be placed on culturally appropriate frameworks, both in gathering data and in designing interventions. And my friend and colleague Stephanie Craig will be up next to talk to you about the work we are doing with funds from the Secretary's Minority AIDS Initiative Fund. Next slide. And you're going to see this graphic in Stephanie's presentation, but I just wanted to tell you a little bit about the cultural appropriate interventions that we know show the most promise in preventing HIV transmission. We know that our work must be culturally appropriate. And programs such as the Project Red Talon and We Are Native, both of which are run by the Northwest Portland Area Indian Health Board, showcase how interventions that celebrate cultural traditions and engage youth in holistic wellness are effective methods in reducing HIV rates. And these interventions highlight the social determinants of health that are cofactors in HIV transmission, such as poverty and lack of access to health resources, historical and intergenerational trauma, substance abuse and alcohol misuse, and exposure to violence. More importantly, they actively engage community members so that programs are tailored to meet the specific community needs. Next slide. We're fortunate to have funds from the Secretary's Minority AIDS Initiative Fund. We also call that SMAIF for short. And just so folks know that the Indian Health Service does not provide automatically free health education and preventive work to the entire country. we get a very small amount of money in our IHS budget. We've got about 2.2 million people in 37 states that are accessing federally run Indian Health Service projects. For all of those people, we get about $450,000 in our IHS national budget. I'm a program of one here at national headquarters. There are no staff besides me. So we rely heavily on our competitive funds that we get from the Secretary's Minority AIDS Initiative Fund. This is administered through the Office of HIV, AIDS, and Infectious Disease Policy. And they're competitive, and a variety of HHS agencies apply each year. Our current funding is around $3.6 million, and we work in HIV across Indian Health Service, tribal, and urban facilities. And we've used these SMAE funds to meet the goals of the National HIV/AIDS Strategy, such as improving HIV testing and care linkage, bolstering comprehensive care, raising viral suppression levels, and expanding access to pre-exposure prophylaxis. More importantly, IHS relies on SMAE funds for virtually all of our HIV/AIDS program dollars. Next slide. And through our IHS funded, through our SMAE funded projects at IHS, we've experienced HIV testing, we've expanded HIV testing and are shown to improve prevention, care, and treatment outcomes among American Indians and Alaska Natives. And as a result of SMAE, our prenatal screening for HIV has increased by 67%. Our overall HIV screening has increased by 63% among our 13 to 64-year-olds. And our hepatitis C screening has increased by 450%. SMAE is doing some amazing things for us. Next slide, please. At the national level, for the very first time, we are really trying to expand our reach and our extension of our services to our LGBTQ and Two-Spirit population. Some of the other things that are happening, for example, at the Gathering of Nations powwow that is held each year in Albuquerque, New Mexico, they included this past year for the first time, a grand entry by our LGBTQ Two-Spirit. Now, IHS didn't have anything to do with that, and I can't say that SMAE did, but what I want to point across is that overall, nationwide, I think things are changing, and we're being much more inclusive. And here at IHS headquarters, I've been able to institute an LGBTQ Two-Spirit work group and put together an LGBTQ Two-Spirit page on our IHS website. Some of us thought that things like that would never happen. And this past June, the Navajo Nation, the largest reservation in the country, sanctioned and sponsored their first ever gay pride parade in their capital city of Window Rock, Arizona. Next slide, please. And over the past 3.5 years, the Tohono Odham Nation in Arizona has made great strides in helping to provide a more welcoming and inclusive community for their LGBTQ persons living on the Tohono Odham Nation. With assistance from members of the Legislative Council, they were able to sponsor and support the creation of their first ever Pride Awareness Month proclamation that came from their tribal chairman. And that chairman is Edward Manuel. This past June, it was crucial that this message of welcome and inclusiveness come from the head of their government as they move forward to end stigma on the Tohono O'odham Nation. It was for many their proudest moments and finest hour. The nation's HIV program talking circle is made up of about 90% gay and men who have sex with men population. The talking circle, provided through funds from the Secretary's Minority AIDS Initiative Fund, is actually holding its first ever drag race on the nation this year in support of World AIDS Day. And this event is something that was unheard of just a few years ago. They have truly come a long way in a very short time, but they still have a far way to go. However, they're working at it and they're getting there one day at a time. Next slide, please. This is just an image of some of the work that's being done around the country to start promoting the message of HIV testing. And sometimes there's a little stigma in communities using certain vocabulary words. And the group in New Mexico found out that just telling someone to get tested for HIV may have been a little off-putting, so they came up with a message just called "We Are Getting It Done." And if you go to their Facebook page, you'll see a lot of beautiful imagery of people and places, and they're using this tagline of "Getting It Done." We are getting it done. And they get to know what that means through their public information campaign. So without actually having to potentially offend someone or turn someone off with just talking about HIV, they're finding culturally appropriate ways to get the message out about being tested for HIV. Next slide, please. I mentioned before that most of our American Indians and Alaska Natives live off the reservation and live in urban and suburban areas. And in fact, in New York City itself, the American Indian House provides a great deal of services to those natives living in the boroughs of New York. One of their big projects that they've started through one of their staff people is called Prepahontas. And it's a teepee project that purpose is to create a discussion and inspire folks to come forth with more information of our own stories. It's called Winter Count, and it's a Lakota tradition of timekeeping. It's an historical account of major events in the life of communities and villages. Traditionally, winter count was done through writings and drawings on teepee or animal hides. And we worked together with the American Indian House to help create some imagery, next slide please, on a teepee that has since been traveling around the country. And you may have, those of you who are at the US Conference on AIDS may have seen this teepee that was set up in the lower level of the hotel. So they took the history of HIV in Indian country and created specific imagery for each one of the years of the last 40 years. And then next slide, please. And this is a view of that teepee. And we've developed a 3-ring binder that people can flip to, look at the image, get the story behind the image. And it's a wonderful traditional way of letting people know that not only are we survivors, but we're thrivers. And we acknowledge and honor parts of our past that maybe weren't quite so honorable, but they're memorable, and we need to cherish and learn and grow from the past. That teepee hopefully will be on display, and we'll keep expanding that so people can learn more about what's been going on in Indian country over the years. And with that, Chip, you can go to the last slide. I'll conclude my presentation there, and I look forward to hearing what Stephanie has to talk about with some specific programs that target our youth.
Thank you, Rick. That was great. Just always quick housekeeping. I saw a few latecomers who joined so far. If you joined late, the entire webinar recording will be available on NMAC's website starting tomorrow morning. Just go to the webinars page of the website and you'll find a link for the webinar library, which will hold not just this recording, but the recordings of all the Community Spotlight webinars from this year. Now I'm going to turn it over to Stephanie Rushing. And Stephanie, can you hear us?
Yes, I can hear you. Can you hear me?
Great. If we can, the floor is yours.
Awesome. Well, thank you, Chip and Rick, for the opportunity to share a little bit about We Are Native. As you mentioned, I am Dr. Stephanie Craig Rushing at the Northwest Portland Area Indian Health Board, and Project Red Talon is actually the longest funded project that we have at the board, focusing on STD and HIV prevention, and more recently, sexual health in a more holistic sort of way. So it's really an honor to be involved in today's conversation. Next slide. The board and our Tribal Epidemiology Center works on behalf of the 43 federally recognized tribes in Oregon, Washington, and Idaho. And Project Red Talon is, as Rick was saying, SNAIF funded. So that's kind of the core funding for the work that we do around STD and HIV prevention for our member tribes. Next slide. And about 10 years ago, our tribes asked us, we had a kind of regional action coalition that was thinking about ways to reach our teens and young adults that are varying in very geographic location across our 3-state region. And we were trying to determine whether we might be able to use technologies to promote adolescent health. And of course, that sounds kind of silly to even ask the question now, but 10 years ago, we were very concerned about the availability of cell phone access and internet connectivity in our various communities across the Northwest. And so we set out to do a little research, and that involved surveying the young people that live in our region, and came to the conclusion that these were good tools for us to consider using to reach teens around sexual health. So we went down the avenue of doing surveys and building out technologies to promote sexual health for our youth in our region. Next slide. So technology, of course, changes very rapidly. So every few years we have to repeat these surveys, and we've broadened from just to the Northwest to a national survey in 2016 on teen technology use and health information seeking. And we had nice participation across the Indian country from 29 states and over 675 youth who participated in that survey. Next slide. And this is really, the sort of data that guides where we message and the channels that we're on. And so we spend a lot of time messaging on social networking sites, giving youth opportunities to access health information on the internet and from their parents, building parent conversation tools. And also the smallest percentage in schools and health class, that's an area that we're working more specifically on as well, to equip schools to deliver culturally relevant health curricula for Native youth. Next slide. So Rick gave you a sneak peek at the We Are Native website. This is kind of the primary multimedia channel that we use to provide health information to teens and young adults. Our goal is really to harness the power of technology to promote protective factors for mental, physical, spiritual, and sexual health. And it was designed with really extensive behavior change theory, informative research with teens and young adults across Indian country. And we change the homepage on a monthly basis. So this is our homepage right now for National Native American Heritage Month. Next slide. So the website has been up and available since 2012. We've had about 500,000 page views from all 50 states. We get about 8,000 website hits per month. The website is very holistic. It covers culture, physical health, mental health, emotional health, in relationships. We find most of our users spend their time in the sexual health content, and so we'll share a little bit of those resources. And then we have other sort of social media that we link folks back to the website to get medically accurate information back from the website. Next slide. One of our most frequently used sections of the website is an anonymous Q&A service, really, called Ask Auntie, and we have over 300 questions that have been submitted to Ask Auntie. So about a third of our website traffic is around this Q&A service, and it's really an opportunity for young people takes away the embarrassment they might have asking questions of their parents or friends or healthcare providers. And the questions focus on everything from identity to relationships, sexual health, and even some questions on oral sex. Next slide. We also have been using increasingly text messaging to reach teens and young adults around health topics. We have a weekly text messaging service. If you text the word Native to 97779, you will receive once a week a message related to the health observance for that month, or information on the website, our monthly contests. And we use that. We have about 5,000 folks that have subscribed to our just general weekly text messaging service. Next slide. We also rigorously evaluated a text messaging series. Folks who enroll in the word sex to 97779 receive 12 weeks of sexual health messaging, and our text messaging service is pretty fancy so that folks can enroll in the service at any time and receive that sequence of messages based on their entry points. And so right now we've had over 400 folks go through the sex messaging series, and when we rigorously evaluated it, we had statistically significant improvements in condom use and also in STD and HIV testing. So we feel like this is a really exciting way to reach young people, and text messages have a much higher open rate and read rate than emails, certainly for this age group. So more and more we're utilizing text messaging to communicate with the young folks in our audience. Next slide. Similarly, we're using the technology to do health messaging around STEM careers, so science, technology, engineering, and math. And if folks express any interest in healing as a profession, healthcare professionals, they receive another series of messages related to the We Are Healers campaign. Next slide. And there's a real strong underrepresentation of Native young people in medicine, and so we are using these channels to help support young people who are interested in health or wellness careers and get them opportunities to do internships and mentoring related to physical health and sexual health as well. Next slide. This past year, we collaborated with the Utah Navajo Health System, and they created a sister site called We Are Navajo, which has some really beautiful, wonderful messaging coming out of their program now. And so it was exciting to see this website launch. And if you are living in that region, you can sign up for their social media streams to get other important sexual health messaging specific to the Navajo Nation. Next slide. Similarly, kind of another branch of the work that we do at the Health Board, we had all of these media channels for teens and young adults and realized that we really needed a place to communicate with the adults that are working with Native teens. And so we put together an intertribal coalition that spent a year working together to build out a website called Healthy Native Youth that would contain culturally relevant health curricula for teachers and parents and other health educators. And we really recognize that in order to be effective, health curricula has to be age appropriate, has to be culturally relevant, and it has to reflect the values and learning styles of the learners being taught. And so this is a place to house those materials for Native teens and adults. Next slide.
Can you hold on one second, Stephanie? I'm having a computer issue here, so give me just a second, please.
No problem.
All right, can you see it now?
I can see the Healthy Native Youth screen page.
Okay.
Yep, perfect. So this is kind of the snapshot of the tribal epicenters across the United States and all the other partners at the Alaska Native Tribal Health Consortium, the Intertribal Council of Arizona, and the CDC and IHS were all kind of partners in building out the Healthy Native Youth website. Next slide. And it's really, really exciting to see it all come together, because 10 years ago, as we were kind of talking as a coalition about offering culturally relevant sexual health curricula, there weren't any that had been rigorously evaluated for Native youth. And over the course of these partnerships, there are now 7 sexual health curricula that are available on the Healthy Native Youth website. They're for different age groups, and all of them have been rigorously evaluated and designed, which is exciting to have all of these programs to offer communities. Next slide. So Native Voices is, I'm totally biased, but one of my favorite. It's a 23-minute sexual health video for Native, heterosexual, and LGBT two-spirit teens and young adults, high school age primarily. Next slide. It includes a lesson plan that can be offered, but it really has been found in our evaluations of it to be most effective when you just show the video by itself. It includes role models of youth that they can relate to, playing basketball at a party, traveling between urban and rural settings, and shows how to negotiate condom use with the partner. There's some funny bits like this clip. Next slide. And we used the We Are Native website to deliver the video directly to youth themselves. So the video has been viewed over 2 million times on Facebook. It's our most viewed video on YouTube, and we do a lot of promotion of it around February, around Sexual Health Month. Next slide. Our most recent addition to the website is a We Are Native Teachers Guide that the Intertribal Council of Michigan has been building out. They are a tribal prep grantee, and they have been adding content to a teacher's guide that already covered sexual health, but building out new content around dating and relationships and consent and drug and alcohol use. So it's a more comprehensive sexual health curriculum that they are evaluating, and it is available on the website as well. Next slide. That kind of covers what I just said, but it is driving folks back to the content on the We Are Native website for more information to get young folks engaged in their own health and well-being. Next slide. So these are our handles for the Healthy Native Youth website, and we encourage you to share them with your community networks, and you can sign up to receive updates on our curricula. At the bottom of our Healthy Native Youth website, there's a little red bar that you can sign up to receive e-newsletters once a month from us. We also have a Facebook page. Next slide. And we just feel that there's no limit to the good work that can be done using technology to promote healthy decision making. So we thank all of you for the work that you are doing to promote adolescent health, and thank you again for the opportunity to share today. Next slide. This is our team, and we're happy to follow up on any questions or resources that folks have, want to be connected to anything I've shared today. Next slide. And of course, the acknowledgement slide. That's it. Thanks.
Thank you, Stephanie, and sorry for that little hiccup there in the middle of it. So now we have some time for questions and answers for anybody who may have questions. Again, you can enter them in the chat box, and we will do our best to answer them. And I'm going to unmute both Rick and Stephanie now so we can ask them to answer any questions they may have. Let me throw one out there just to start. What do you both feel is currently the biggest challenge the community faces in responding to the HIV epidemic?
This is Rick. You know, I think probably people always want to say resources and money. And while that's always going to be an issue for us, I really think that we're still dealing with a lot of stigma, both in our communities, in our people who are LGBTQ2 spirit, in our people who are at risk for HIV, people who are living with HIV. I just think there's still an overwhelming amount of stigma that keeps us from freely talking about the issues that we need to talk about when it comes to dealing with HIV prevention and treatment, as well as the new thing they're all trying to get across is the treatment as prevention. So getting people to talk about PrEP means they have to talk to their doctors about their sexuality. It means doctors have to be open to talking about men who have sex with men. It means our communities and our leaders have to promote the idea that PrEP should be available in our clinics, which, by the way, we just got approved a few weeks ago to put PrEP in all of our IHS clinics. But I think stigma is one of our biggest hurdles.
Yeah, I would totally agree. And I would say just for, our young folks in particular, awareness of HIV, I think, is down. And so just recognizing HIV as an adolescent health concern is still important messaging for us.
Okay. I don't think we have any additional questions yet. We'll give it a couple more minutes. To both Rick and Stephanie, is there anything you didn't get a chance to cover today that you'd like to bring up here for the attendees?
Well, I touched on it just a second ago in my last comment, the idea of PrEP. We've been working really hard to get PrEP in our IHS clinics. Some of our clinics have done a really good job in using the patient assistance program to the drug manufacturer to get PrEP prescriptions, but we are really happy and excited that now people who walk into an Indian Health Service clinic can ask for PrEP and probably walk out the door with it that day, or at least on their next visit. So that's a huge step in our treatment as prevention of HIV. And we can't forget those people living with AIDS. We're doing a really good job in our clinic in Phoenix. In fact, they're winning awards for their ability to keep people undetectable. So if we can get more folks to emulate our Phoenix Indian Medical Center, but I think a lot of that work comes from some of the grassroots work that Stephanie and her folks are doing.
Great. So far, I know the further questions, although we do have one attendee who really, and I echo this, loved the teepee. I thought that was great as well. So I think that's an interesting tool to use. So we'll give it another little bit of questions. And seeing none, I'm going to thank you all for attending today. Our next and final Community Spotlight webinar for NMAC will be December 12th, and we'll be focusing on Puerto Rico after Hurricane Maria. So I hope you all do join us for that. Again, information for that and registration information is available at nmac.org/webinars. And seeing no further questions, I think that's it for the day. Thank you all so much for attending. Thank you, Rick and Stephanie, for presenting today. It's very helpful information. Again, full recording of the webinar will be available on NMAC's website starting tomorrow. If you missed part of it or if you want to share it with other folks, it will be available there. Thank you all and have a great rest of your day.
Thanks, Chip. Bye.
Thank you.